to do, and hopefully maybe another one in this next year. I'll be glad to answer any question about anything else. Yes?
How much function can you expect to have?
If it guides on what we've done in the past, Scott is out 7 years. Our first one, he has about 90% function to his hand. As far as gross function is concerned, we'd expect Donnie to have within 6 months or a beat 70%. What he won't have is the nerves, and the nerves is the longest to recover. It takes anywhere up to 6 months to a year and a half to get sensation back, and then to get back the innervation to the individual muscles of the hand. It's just the same thing as if somebody had a transplant or a replant of their own hand. It takes that long. But his repairs, his muscles were good, his repairs were excellent, and we feel he's moving right now at this point better than some of the others we have had. So we're enthused that we'll get him started much quicker and getting his function much quicker.
Can you tell us a little bit about Donnie, what he does for a living, how this is going to improve his quality of life?
Well, I honestly can't tell you. I know he injured this in a punch press injury. He injured both hands, and he did that. Honestly, I can't tell you if he's been working now or not. I know he has. He still has some inability to use his right hand normally. He has some ulnar nerve that's been damaged, so he has a claw hand where he's got these 3 fingers in the right hand only that he works with. And I'm not sure if he has been working or not. But
Okay.
okay.
That's okay to interject. He is on disability, so he has not been working.
But hopefully by all the patients that we've done so far have gone back to their previous jobs, and except Dr. Edwards yet has not gone back to being a chiropractor. But the others have all gone back to work. In fact, I think our second patient, Dr. Savage, or Mr. Savage, just kind of retired. He had his own business. I know our third patient is still putting up gutters on houses in Michigan, and so he's still working. And most of the others are. But so this means that these people are capable of going back to some type of earning a living, and rather than being on the dole, so to speak, of the handout.
The 8th transplant, are you still learning new things with each transplant?
Each transplant is different. It's not. It's different in relationship to what parts were there and what parts are missing. The simplest is a straight amputation, so that there's nothing distally. Mr. Edwards, Dr. Edwards, and Donnie had a little bit of a portion of their hand left that he wanted to try to save the nerves to and things like that. So it took a little bit more time in dissecting out and removing that and saving as much as possibly could. But each one is different. The first one, when we did Scott, he ended up finding that he was short of tendons, so we ended up having to do additional tendon transfers and taking some tendons from his legs. These are things that you don't know until you get in and examine the part that's been amputated and the residual part. Anything else?
I can add another question, answer. That's
Well, I have one more question for him.
Sure.
Okay, before we go back to Andrew's
Yeah.
question. How does the surgery work itself? You said you have 15 surgeons in the room. Are you guys working in rotation?
Rotation.
It's 14-hour surgery. Does one thing work for 30 minutes or an hour? How does the surgery actually work itself?
Well, basically, it's like saying, okay, you've got the bones to fix, so one team fixed the bones. You've got to dissect out the parts, all the parts on the donor hand. So one team dissects them all out. We have markers, and we mark what they are, or which flexor to which finger, which nerve goes where, and everything. Those are all marked on the donor's hand. In turn, on the recipient hand, I took care of this one initially, and I dissected everything out, marked all the muscles, marked all the tendons, marked everything that had to be hooked up to. So when we bring the two parts together, we got identification. And when the tendons were put together, Dr. Tuna worked on the tendons. as I told Dr. Marino, worked on the bones. As soon as we got the bones attached, because of the time of ischemia, the next thing we did is hooked up the arteries. And Dr. Sy hooked up the arteries and the vein, what we call vena communicante vein, which is a small vein that goes alongside the artery so that there'd be blood going in and out of the heart. And then after that, I kind of asked guys what they want to do, so they went in and did certain parts of it. And it ended up with a couple of our fellows doing some veins at the end, and Dr. Panatani, and the skin flaps and things were put together. So it's assigning jobs, basically, and making sure that everybody is not exhausted so that they'll do their jobs. And we had people bring in some food and pizzas, and
That's what I was going. How do you keep your strength? How do you go through a 14-hour surgery?
Well, some of them just took naps and lay down to take a nap, and then the others were home, and then they came back in later at different points along the line when you know what's going on. I think I was the only one that stayed awake the whole time. But that's because I'm used to that. These younger people aren't used to that. Anything else? Well, thank you again and I just wanted to reemphasize that this program is going. It's strong, and it will continue to go. And we hope we'll have at least another one or two in the next 6 months or so. Our biggest problem is donors. Everybody knows that that's a problem. It's easier to get a donor who will give up a kidney or heart or liver because when they're in the casket, nobody knows that those parts are missing. But if you're in a casket and you're going to have the person exposed, the hands are in the casket. So it's very difficult for families to give up a hand unless they're going to cremate the body. Again, he's going to change. We're going to change his dressing this afternoon. He will start his physical therapy. We usually start in about 2 to 3 days. So, and most likely about Friday we'll probably put him in dynamic splints where he can actually function and work with his hands.
How long before you could be completely out of the hospital following?
Well, they stay in town for 3 months, so we follow them very closely for 3 months. And so that means that they come in for therapy and guidance and things that have to be done. He'll probably actually be in the hospital, I think if the average is a week and a half, and then they stay in a location here in town.
Can you repeat the anti-rejection drug?
My expert. He could even spell them for you.
Yes. It's called thymoglobulin, which is THYMOGL, OBULIN, globulin. Okay. The team is very redundant. You asked the question about, who's doing what part of the operation. The team that they have here is so well trained that each surgeon can do multiple parts of the operation. So depending on what surgeon's doing which part, another surgeon can step in and do a similar part. So that's why it's not set in stone who's doing what. But the team there's such a depth of knowledge in the hand surgery arena here with Kleinert and Coots that we are able to perform an operation that lasts that long and have the patients still do well.